Ultrasound detectable skeletal dysplasia, thanatophoric dysplasia case study. Skeletal dysplasia is an overarching term used to encompass abnormal growth and density of both cartilage and bone. Because this is a broad term, it is used to reference a spectrum of diagnoses that are linked to such abnormalities. There are more than 100 kinds of skeletal dysplasias, both lethal and non-lethal. However, only a handful of them can be detected sonographically. Incidence of skeletal dysplasia is 1 in 4,000 to 5,000 births in the United States. To name a few, through the use of ultrasound, sonographers can detect these short-limbed skeletal dysplasias such as non-lethal achondroplasia or lethal osteogenesis imperfecta type 2, achondrogenesis, camptomelic dysplasia, short rib polydactyly syndrome, hypophosphatasia, and thanatophoric dysplasia. To briefly cover what each of the ultrasound detectable skeletal dysplasias are, we'll break them down slightly. Achondroplasia is a dwarfism-related disorder. It is the most common non-lethal skeletal dysplasia and separated into two types, heterozygous and homozygous. Heterozygous achondroplasia is inherited from one parent. People with this type survive and are typically of normal intelligence. Homozygous achondroplasia is lethal, however, due to the narrowing of the thorax and respiratory problems. Through the use of ultrasound, we would find that the fetus would suffer from rhizomelia and trident hands. Rhizomelia is the shortening of the proximal bone segments. Trident hands is defined by short proximal and middle phalanges. Osteogenesis imperfecta is a collagen disorder which affects the bones of the fetus. There are 4 types, of which type 1 and 4 are the mildest, resulting in brittle bones. Type 1 osteogenesis imperfecta is typically characterized by fractures in the vertebrae as well as blue sclera. Type 3 is more severe and detectable via ultrasound, but type 2 is the most severe, often resulting in fetal demise due to pulmonary hypoplasia. Sonographic findings of osteogenesis imperfecta type 2 include hypomineralization of the skull and multiple bone fractures. Achondrogenesis is another rare but lethal skeletal dysplasia. It is caused by abnormalities of the cartilage and hypomineralization, which is similar in findings of osteogenesis imperfecta and consists of 2 types, Parenti-Fraccaro, which is type 1, and Langer-Saldino, which is type 2. The most severe is type 1, and it is autosomal recessive. The sonographic findings of achondrogenesis include severe shortening of limbs as well as decreased ossification of the skull and other bones. The prognosis for achondrogenesis typically presents infants either being stillborn or perishing from respiratory complications soon after birth. Camptomelic dysplasia, otherwise known as bent bone dysplasia, is a collective name for lethal skeletal dysplasias that are characterized by bowing of the long bones. If the infant survives birth, death will usually occur within the first year of life due to respiratory issues and feeding problems. Intelligence is also affected as infants are typically developmentally delayed. The distinguishable sonographic findings of camptomelic dysplasia include fibular hypoplasia and the aforementioned bowing of the long bones. There are 4 primary types of short rib polydactyly syndrome. Type 1 is referred to as Saldino-Noonan syndrome, type 2 as Majewski syndrome, type 3 as Naumoff syndrome, and type 4 as Beamer-Langer syndrome. The lethal nature of this syndrome stems from pulmonary hypoplasia. It's characterized by short ribs and limbs as well as polydactyly, or, in other words, more than the normal amount of digits on the hand or feet. Hypophosphatasia is a skeletal dysplasia that is an inherited condition of which the fetus presents with diffuse hypomineralization of bones due to a deficiency of alkaline phosphatase. This specific type of skeletal dysplasia is sonographically similar in nature to osteogenesis imperfecta as well as achondrogenesis. However, the diagnosis is confirmed via a sample of fetal blood to prove the alkaline phosphatase deficiency. Respiratory complications are typically the cause of the lethal nature of this syndrome due to a small thoracic cavity. The last ultrasound detectable skeletal dysplasia that we will talk about is thanatophoric dysplasia. This lethal short-limbed skeletal dysplasia is the most common of the lethal skeletal dysplasias in that it affects 1 in 4,000 to 10,000 births. There are two different subgroups of thanatophoric dysplasia labeled types 1 and 2. Both subgroups are considered lethal, and most infants will perish shortly after birth due to pulmonary hypoplasia. Type 1 presents sonographically with shortened, curved long bones of the lower extremities and flattened vertebrae. In contrast, type 2 is characterized by shortened but straight femurs, flat vertebral bodies, and the addition of a cloverleaf-shaped skull. The cloverleaf skull occurs typically when there exists a premature closure of the coronal and lambdoid sutures, creating a trilobed skull. Most cases of thanatophoric dysplasia occur sporadically with the mutation of the fibroblast growth factor receptor 3 (FGFR3) gene. A diagnosis of thanatophoric dysplasia can be prenatally confirmed by conducting a molecular analysis of the FGFR3 gene. This analysis is conducted via extraction of the fetal cells through amniocentesis if gestational age is between 15 to 18 weeks, or with chorionic villus sampling if the fetus is between 10 to 12 weeks gestation. Not unlike the rest of the lethal short-limbed skeletal dysplasias, this type also affects the pulmonary system. With presentation of a narrowed thorax and shortened ribs, these anomalies usually lead to death due to pulmonary hypoplasia. Next, we will talk about the case report of the infant with thanatophoric dysplasia. In this case report, a diagnosis of thanatophoric dysplasia is examined in a stillborn fetus. It is the most lethal skeletal dysplasia of which is caused by mutation of the FGFR3 gene, and most fetuses die in utero or shortly after birth because of pulmonary hypoplasia. Due to patient history, sonographic findings, and the post-mortem evaluation, a further diagnosis of thanatophoric dysplasia type 1 is deducted. The patient was a 24-year-old female on her second pregnancy with a history of one spontaneous abortion when the fetus was 2 weeks gestation, followed by dilation and curettage with no follow-up. She had not come in for any imaging or care prior to this examination. The patient came in with amenorrhea for 8 months and spotting for 1 week. She had no history of fever, rash, spotting, drugs, or radiation exposure during her pregnancy. The patient was not a drinker or a smoker and had no addictions to drugs. There was not any family or personal history of congenital abnormalities, and her vitals were normal. The patient's complete blood levels were obtained showing increased white blood cell count. However, other levels, such as sugar, LFT, and KFT levels, were of normal values. Upon sonographic investigation, it was confirmed that there was a live intrauterine fetus in breech position. There was increased thickness of the placenta at 4.7 centimeters in the anterior-posterior axis. Images of the fetal cranium showed the third and fourth ventricles were enlarged, as well as a prominent cisterna magna measuring 12 centimeters, which suggested hydrocephalus. While recording these abnormalities, no cloverleaf skull deformity was noted. Moving on to the thoracic cavity, it was noted that the narrowing had occurred along with gross ascites within the fetal abdomen. The extremities presented shortened long bones and curved shape to the femur. Amniotic fluid surrounding the fetus was reduced with an AFI index of 3. The fetal biometry measurements showed a range of gestational age approximations from 16 weeks 5 days in the measurement of the humerus to 33 weeks 2 days in regard to head circumference. Image number 1 in the upper left shows the dilated third and fourth ventricles. The image number 2 shows the prominent cisterna magna. Image 3 shows the fetal abdomen with the ascites, and image 4 shows the shortened femur on the left and the shortened humerus on the right. Although most sonographic features point to thanatophoric dysplasia type 1, there are still other possible diagnoses to consider. Based on the short-limbed skeletal dysplasias exploration, other differential diagnoses could be camptomelic dysplasia. This skeletal dysplasia is characterized by the bowing of the long bones and the telephone-like bowing of the femur. Achondroplasia and achondrogenesis could be differential because it is characterized by rhizomelia, the shortening of the long bones, and in this case, the humerus and femur lengths were extremely shortened. Hypophosphatasia could be suggested as well due to the limb shortening and bowing of the long bones. Due to her lack of appropriate amniotic fluid, the patient was induced into labor, delivering a premature female baby. The baby did not cry and was noted as stillborn, looking dysmorphic. Sonographic findings were confirmed upon examination after birth with open cranial sutures, shortened upper and lower limbs with stubby fingers, a narrowed thorax with protruding abdomen was also confirmed. Also noted was the presence of edematous face and frontal bossing, midface hypoplasia, and other facial anomalies. These anomalies, along with the ultrasound diagnosis of the bowing and shortening of the bones, led to the diagnosis of thanatophoric dysplasia type 1. Second trimester identification of a lethal skeletal dysplasia is typically straightforward. However, due to the knowledge that this was the first examination of the pregnancy, early detection of the skeletal dysplasia was not possible, and the final diagnosis was made after birth. If there had been an antenatal ultrasound, three-dimensional imaging would have helped to see the facial anomalies noted after birth to aid in early diagnosis. There was also no assessment of the FGFR3 gene, which is defining in factor of the formation of thanatophoric dysplasia. Mutations with this gene would show that there is an absence of growth factors in the gene causing abnormal growth of long bones. Assessing this through amniocentesis would have aided in diagnosis prenatally, but was not cost-effective in this case. Although no other imaging was taken, other reports suggest that X-ray can be used to further prove the diagnosis of thanatophoric dysplasia. Radiographs can present a second confirmation that in fact no premature fusion of the sutures was present to suggest cloverleaf skull. Also confirming the bowing of the long bones further differentiates thanatophoric dysplasia type 1 from type 2. Not much was mentioned of patient care in this case report. However, when looking at the tests that were not performed, better patient care could have been established on that front. Unfortunately, since the mother did not come in for a fetal survey, absence of early detection is not the fault of the medical team and could not have been anticipated. One could also argue that post-mortem x-rays would have helped to solidify the diagnosis and assure the correct measures were taken to close this medical case. There are many types of skeletal dysplasias. Ultrasound is capable of detecting a variety of different types prenatally, but more specifically the short-limb skeletal dysplasias. Those consist of the non-lethal achondroplasia, lethal osteogenesis imperfecta type 2, achondrogenesis, camptomelic dysplasia, short rib polydactyly syndrome, hypophosphatasia, and thanatophoric dysplasia. There are many different factors and distinguishing characteristics that can differentiate one dysplasia from another. Thanatophoric dysplasia, the most lethal of the skeletal dysplasias, has two different types. The case report of an infant with thanatophoric dysplasia type 1 evaluated the patient's clinical symptoms, ultrasound findings, and lab work to assess the pregnancy. The medical team was able to give their final diagnosis after birth due to the nature of the case. Since many of these short-limb skeletal dysplasias are so similar, it further proves the importance of early detection and multiple tests for confirmation. Doing so will continue our understanding of skeletal dysplasias.